Welcome to this session, this webinar, FIP webinar, really anchored by the African Pharmaceutical Forum. So we'll be looking at AMR and AMS in private health facilities in Africa. You're welcome. My name is Yvonne Yirenkyiwaa, and I'll be your moderator for today. I am Rector of the Ghana College of Pharmacists. I'm also a member of the FIP AMR Commission and a member of the African Pharmaceutical Forum. So this webinar is being recorded and live streamed. So maybe if there is somebody who is not able to join, but will still want to participate, they can join us on YouTube. And after the program, the recording will be available on our website at events.fip.org. And you will find that we have a question box which has been provided where you can put all your questions in as the presentation goes on, and maybe ask if even as the panel discussion is going on. We will also be happy to hear from you, your feedback. Send them to webinars@fip.org. And we encourage you, once you are here, if you are not an individual member of FIP, please join FIP. And the link has been provided. Join us. So we have a new translation feature, which has been provided by Zoom. So you turn on captions, and that allows you to enable translation. You choose the language that you want, and you can go through as the pictures show over here, and that will allow you to hear us in a language of your choice. So for today's program, we've done the introduction for the program. We are going to receive a presentation on our topic by Dr. Cornelius Dodoo. And after that, we will have a panel discussion. We've put together a great team who will be leading the discussion, and we'll be happy to hear from you if you have any questions and answers. And as the conversation goes on, whether it's in the presentation or during the panel discussion, please put your comments in the chat box and also put your questions, some of the questions. And if somebody puts in a question and you think you have an answer to that, go ahead and answer it. We are all here to learn. After that, we will receive a Q&A session. So after the panelists have looked at their questions, which we want them to answer, we'll also hear from you and pick your questions and ask if you want to a particular speaker or a particular panelist to answer. You can identify and we will address it to them. If you want a general and anybody can do that, we will also let anybody who is ready to answer accordingly. And then after that, we will have a few announcements and close. We are hoping that when we have finished, everyone who has participated in this webinar will be able to identify various sources of poor antimicrobial use and also misuse in private health facilities across the continent, identify roles and responsibilities of pharmacists and other healthcare personnel in the fight against AMR in private health facilities, and to engage the panel in a discussion that will identify the strategies and methods that will help in curbing AMR and also help in promoting AMS in private health facilities across Africa. We are focusing on private health facilities because we realize that a lot of stewardship programs are based in public institutions, teaching hospitals, regional hospitals, hospitals that, big facilities that are government owned. But we know that a lot of antibiotics are used, antimicrobials are used in the private sector, whether they are community pharmacies or private clinics or all those facilities have these antimicrobials. And it's important that we see how we can take the stewardship from or build on it, leverage what we know so far and use it for our private health facilities. And so having said that, I will ask Dr. Dodoo, who is a senior lecturer at the School of Pharmacy, University of Allied Health Sciences in Ghana, to take over. Dr. Dodoo, you're welcome.
Thank you very much, Dr. Esseku. Yes, so I'm Cornelius Dodoo, a senior lecturer with the University of Health and Allied Sciences. I'll be talking briefly about antimicrobial resistance and antimicrobial stewardship in private healthcare facilities in Africa. The outline for my talk is as indicated. I'll give a brief introduction, talk about the roles of private healthcare facilities, drivers of inappropriate antimicrobial use in private health facilities, ways in which we can improve antimicrobial use in these facilities, and then a few case studies. Next slide, please. Yes, so for an introduction, I mean, when we talk about antimicrobial resistance, we are basically talking about a situation whereby microorganisms that typically would be killed by certain drugs are no longer being killed by these. This is a great public health threat globally, and more so in Africa, where we have fragile health systems and high infectious disease burdens. This is a great challenge. Global research on antimicrobial resistance reports that was published somewhere in 2022 indicated we have about 4.95 million deaths being attributed to AMR. This was somewhere in 2019, data collected from 2019. And even in that data, a greater chunk of that number was from Sub-Saharan Africa. A number of factors contribute to antimicrobial resistance. You talk of inappropriate prescribing, be it the misuse or overuse of antimicrobials. Talk of poor infection prevention and control. I mean, if infections are not prevented or controlled properly, you tend to use a lot more antibiotics and other antimicrobials, which in effect increases antimicrobial resistance. You talk of substandard and falsified medicines. That is another serious challenge in Africa. I mean, the concept of killing bugs or killing microorganisms is based on exposing these organisms to a set amount or concentration of antibiotic over a set period of time. In instances where you have substandard antimicrobials, you don't get this kind of relationship or contact existing, and these microorganisms over time build resistance and it becomes problematic killing them. Then we have poor surveillance and diagnostics. In as much as possible, you want to know the microorganisms you are getting rid of, and diagnostics will help you to do that. When you have poor surveillance and diagnostics, you tend to treat blindly most of the time and do a lot more empiric treatment, which we don't really want to be doing most of the time. And the poor surveillance doesn't help us to track our resistance patterns and antibiotic use over a period. To address this, we usually implement antimicrobial stewardship programs. And this basically refers to coordinated strategies to improve the use of antimicrobials. The ultimate goal is to enhance patient outcomes and minimize unintended consequences of antimicrobial use, be it the side effects or resistance. When you look at the infographic on the right, we have certain, we refer to them as core successful stewardship programs to be instituted. You want to have leadership support. These are the people you would go to for resources, and you need their backing to do whatever you are going to do. You want to hold certain people accountable. So we tend to form stewardship committees and stewardship teams. And yes, you need the knowledge to be able to do whatever you want to do. Other core components, we have the education, and this education is not just a one-off education. We're talking about continuous education because the field of healthcare is evolving, and the field of Getting rid of microorganisms is also evolving, so you want to be up to date with current trends. You want to track whatever is going on. So we talk of surveillance, be it your antimicrobial resistance patterns or your antimicrobial use patterns. You want to be in the know of these. And, you want to have action. It's not just about talking. You want to walk the talk. So you need to drive the agenda. And finally, we talk of reporting. Yes, there are several stakeholders involved in addressing antimicrobial resistance. And at any given point in time, it's only fair that you keep them up to date in whatever is happening, be it good or bad. Back to the point. So for some time now, AMS interventions have mainly been focused at the hospital level and mainly in public hospitals. And it is very important that we bring private healthcare facilities into the frame. Next slide, please. Yes, so these private health facilities have a significant role when it comes to the delivery of healthcare across the continent. When you look at the numbers, you realize that a great percentage of populations do access these private health facilities. And I mean, by private health facilities, we're talking about private hospitals, be it large or small, specialist clinics, your fertility clinics and the like, and then community pharmacies, which most often are not the first port of call we reach out to when we need medications or healthcare. It's been reported that there are a number of reasons why people prefer these private healthcare facilities. We talk of perceived quality of care. It is assumed, or it has been reported or known, that most of these private healthcare facilities have better infrastructure as compared to the public ones. So most people tend to prefer these facilities. You talk of increased contact time with healthcare workers, be it your prescriber, be it the pharmacist, be it other healthcare workers. The contact time is usually higher. Talk of shorter waiting times because the numbers are not as you find in the public spaces. You don't tend to wait a lot on, even if the numbers are huge. In most of these places, you tend to have a lot more staff, so the waiting times are reduced. And others have also reported that these private healthcare facilities are a lot more hospitable as compared to the public ones. However, there are a couple of challenges or gaps when it comes to antimicrobial use in these private facilities. The first, you talk of staffing. And with this, with these private hospitals, you tend to have a bit of extreme. You have the bigger ones, which may be well-staffed, but what about the smaller ones? There are challenges with staff, and then even where the staff are present, the quality of the staff you have there. And for proper stewardship, you need staff who have adequate time, and then you need staff who are well knowledgeable in the area. You talk of inadequate diagnostic supports. Because some of these private health facilities don't have the appropriate infrastructure, they tend to do a lot more of empiric antimicrobial treatment, and that tends to let them use a lot more broad spectrum antibiotics, which typically you don't want to be using. Then there are the issues of procurement. In your typical public institution, procurement is done via tendering. So there is a rigorous process that anything that is brought into the facility goes through. And this ensures that to some extent quality products and medicines are brought in. But when you look at the private health facilities, most often that this has been done by an individual, and quality can easily become compromised because that person may not be able to do the needed checks to ensure that the right products are brought in. Then we have the implementation of guideline-based prescribing. In your public institution, there are certain checks and balances and other higher bodies you report to. But with these private facilities, aside the staffing issue, which may make implementing these guideline-based prescribing a challenge, oversight is also a bit of a challenge. So it is a bit difficult to implement guideline-based prescribing. Then you've got financial incentives. I mean, most private facilities are operating on a profit-driven model, and this is based on numbers coming in and sale of medications. And I mean, if you are going to make profits based on how many medications you sell, you can easily become compromised into doing a lot more antibiotics even when it's not needed, and that can become problematic. We tend to find ourselves in an environment where patients typically expect medicines or antibiotics whenever they visit our facilities. Someone may walk in with a common cold, and that person would want an antibiotic to be prescribed, and that is a problem because you don't need antibiotics for everything. There is the regulatory aspect as well, where access to antibiotics is quite readily available in Africa. And there are certain institutions that you typically don't want antibiotics to be available or to be sold from, but you tend to find these in our situations. So access to antibiotics makes it's also another driver to inappropriate antibiotic use in private healthcare facilities. Then we've got training. Your typical pharmacy students or pharmacy, your typical graduates from a pharmacy program would not have a lot antimicrobial stewardship being taught at the undergraduate level. Most of these are done at the postgraduate or other advanced programs. And in a situation where you tend to have graduates from just the pharmacy programs running your facility, there are gaps in the knowledge unless these people have taken it upon themselves to do some further reading on their own. So our typical curriculum doesn't really address stewardship. And I'm happy we have a lot of academics on the panel today. And I think that is something we can discuss. And then there is the absence of antimicrobial stewardship programs in a number of these private health facilities. And it's mainly due to management approval, because for a successful stewardship program, you need leadership support or management approval. And in instances where you don't have this, it becomes a bit difficult or tricky to implement. Next slide, please. There are a number of ways in which these gaps or challenges can be addressed. First and foremost, you need to have the knowledge. You talk of education and capacity building. Yes, even though the undergraduate program may not fully address the needs when it comes to stewardship, there are several online modules on several platforms that as an individual you can access and then upgrade yourself. You talk of the World Health Organization, the Centers for Disease Control and Prevention, the Commonwealth Pharmacists Association. All these agencies have got modules on their websites that are free and you can readily access to learn more about the field. You talk of AMR or AMS-related webinars like we are having now, being organized by the FIP, the International Center for Antimicrobial Resistance Solutions. I've also got a number of webinars on their website that you can access. Global Health Partnerships, formerly TET. They also have a number of resources available that individuals can subscribe to and then build capacity. Then you talk of facility level training, whereby the facility takes it upon itself that it is going to train certain people who are in turn going to train others in their facilities. And this can also be done at the point of recruitment, whereby any new recruits are taken through some level of training on stewardship. Then we have practice group training. So with this, typically, you talk of associations, be it private healthcare providers, be it community pharmacies, whatever practice group they belong to. There are certain CPD-based modules available in a number of African countries that can be accessed to build capacity. It is until your capacity is built that you can go on to educate the public, because you can only give what you know. So, and even when it comes to public education, yes, we tend to hear a lot during World Antimicrobial Resistance Awareness Week. This is good, but I don't think this should be the case. Education should be an all year round thing. Next slide, please. Then we talk of behavioral change. And with this, I'll talk about it at three different levels. So in our hospitals, we need to look at our prescribing habits as prescribers. And community pharmacies, can we treat antibiotics as prescription-only medicines and dispense them only with antibiotics? And then as consumers as well, it is high time we stop requesting for antibiotics. If you need an antibiotic, certainly your healthcare provider would give you one. You shouldn't go asking for it. And then we should look at how to restrict access to antimicrobials and antibiotics and then treat these as prescription-only medicines. We can also institute antimicrobial stewardship programs. So this has to do mainly with the hospitals whereby you have your stewardship committees being formed, you are building capacity, trainings being conducted for staff to build their capacity, and then surveillance. Periodically, you want to know what exists on the ground and how best to improve upon it. And then you can, this stewardship program as part of it, you want to have policies or guidelines on antimicrobial use. And then at the national level, it is important to integrate the private sector into national AMR action plans. I know across a number of countries, this document or this plan is being reviewed. We need to involve our private sector in the design of these action plans. It is also important to involve them when it comes to the implementation and evaluation of national AMR strategies. Even when it comes to reporting to surveillance platforms, top of the glass reports, it is important to get our private healthcare facilities to report on their antimicrobial use and resistance. Next slide, please. All right, so I'll talk about a few case studies that I have been involved in. So I'm also involved in a health partnership that is between University College London Hospitals, University of Health and Allied Sciences, and Hull Teaching Hospital. And what we basically do is to promote antimicrobial stewardship in the Volta region. That is where we work the most. So one of the things we've been doing with the private health sector, mainly the community pharmacies, and most of what I'll talk about can be applicable to the private hospitals and clinics as well. We periodically conduct education for staff of the community pharmacies. And what we do is we try to deal with the fundamentals of antimicrobial stewardship and resistance because they need the knowledge. And then we also help them with certain tools. I'll talk about one later on. But you know, most of these staff are adults, and when it comes to adult learning, it's about how you designed it, and we make it as interactive as possible. So you can see an AMS game being played there as part of our training, and through that game, you learn a lot. And then, you know, we just try to make this as frequent as possible to make the education continuous. Next slide, please. I spoke about the challenge when it comes to procurement in private health facilities. So one of the approaches we have adopted to address this is by coming up with a checklist that would assess the quality of antimicrobials. We've done this in a number of community pharmacies in the Volta region. And it's a very simple checklist that is based on visual examination. And you're looking at general information. So you check in the product name, the dosage form. You want to have these on whatever product you are buying. The language, if you're in an English-speaking country, it is only fair that any medicine you are buying should be in English or should have the translation. If this is not the case, how do you know the side effects of whatever you are buying? You want to see the country of origin and some details of the manufacturer on the product you are buying. You want to have ensure that whatever product has been registered with the Food and Drugs Authority from your country. So you can check the status with the Food and Drugs Authority in Ghana. This is available on their websites. They also have contact numbers you can call to verify these. And any product that has been registered has got an FDA number. So you can verify this with the agency, with the authority as well. And then you talk of the quality of medical information. I mean, you want the grammar that is on the products you are buying to be correct. If you have a product with a number of grammatical mistakes, and be it on the packaging or the information leaflet, I think it's a red flag that you want to double check to be sure that the product is of good quality. Then you look at some batch information. So you want to verify that there's a batch number, there's a manufacturing and expiry date all captured on the products. You look out for certain security features, barcode, serialization. You want to make sure that the product is properly sealed. It hasn't been opened initially, and all that would, if you have a product that these are not present, it's a suspicious product that you just want to double check with the right authority to be sure that it is appropriate. Another thing we initiated in our work is launching a Take Back Unwanted Medicine program. So yes, we are all aware that we have a number of antibiotics in our homes. How do we get these out of our homes? We don't want to encourage the practice where individuals put these in their bins or flush them down the toilet, because eventually they end up in the environment with worrying effects. So we launched this campaign together with the Food and Drugs Authority, whereby we have take back bins in a number of community pharmacies across the region. And we encourage and educate the public to return these so that eventually would reduce the antibiotics and other antimicrobials we have in our homes and the environment. Next slide, please. All right, so in conclusion, antimicrobial resistance is a complex topic with a high prevalence of misconceptions and misunderstandings. Increased awareness about antimicrobial resistance and an understanding of responsible antimicrobial use will allow individuals to be good stewards of antimicrobials. There is, however, the need to bring a lot more private health facilities into the conversation. AMR is a fight that, as an individual or as an institution, is very difficult to deal. So it is something that's all hands on deck as multidisciplinary, multi-stakeholder, all the multis you can think about. You need to have them on board so that we can address this. Next slide, please. Yeah, so these are some references I got some of my information from. Next slide, please. And then these are some of the sources I got the photos that I used in my presentation from.
Thank you so much. Thank you very much. And I will stop sharing and ask all our panelists, please put on your cameras and microphones so that we can see your faces while we go into our panel session. So yeah, and I'll also encourage that perhaps with a view, we can set our view so that we see all the panelists at the same time. I will briefly introduce the panelists, and then I'll start off by asking them a few questions. Dr. Dodoo, we've heard what you have said, what you are doing in the Volta region. Other panelists from across the continent to let us hear what is also happening on their side. And today with us, we have Winnie Nambatya at the pharmacy department in Makerere University, Uganda. Rebecca Soremekun, professor in the Department of Clinical Pharmacy and Biopharmacy, Faculty of Pharmacy, University of Lagos, Nigeria. Samuel Egeye, professor, computational pharmacology and
Seems our moderator has hung a bit. Give her a few minutes. Okay, she's up. So, permit me to assist her in completing the introductions. We have Samuel Egay with us, who is Professor of Computational Pharmacology and Cheminformatics Group. Okay, she's back. So welcome back. Go ahead, ma'am. Are you back? Dr. Esseku, can you hear us?
Yes, yes, I can.
Please go ahead. Go ahead with the introduction since you're back. I was still on Sam Egay's. I was still on Samuel Egay's.
Yeah, just finish it up for me, please, and
All
then
right,
I'll take over with the questions. Yeah.
Okay then. Thank you. Okay, so we have Professor Samuel Egay, Computational Pharmacology and Cheminformatics Group of the School of Pharmacy, University of Western Cape, and Western Cape in South Africa. And finally, from North Africa, we have Professor Mohamed Adil Selka, is a professor in the University of Tlemcen in Algeria, and is also a vice president of the Federation of Algerian Pharmacists. You are very welcome, all of you, to the discussion.
Thank you.
Drop again?
Yeah, I'm here. So thank you very much. And I think the first question I'll just ask in any order at all. I'll ask that you tell us what is happening in your country. What are some of the issues that, with respect to AMR, perhaps maybe you can highlight on things that may not have been mentioned by the speaker. If it is something that maybe it's a very big thing, and so you still want to talk about, the speaker has mentioned it, but you also want to speak about it, that's also fine. But tell us something about what the situation is in your country. And I will, I think in any order at all, just take it. There are just 5 of you, and so we should be able to go through orderly. Professor Mohamed Selka, I can see your picture, so maybe you can start.
Yeah, good morning, everyone. First of all, I want to thank the FIP for the organization of this timely and vital discussion. It's a privilege to be a part of a global initiative tackling antimicrobial resistance. So for the question, what are some issues that affect MMI and MIS in private facilities in Algeria? So in Algeria, we have many similar healthcare systems. Private facilities face multiple interconnected challenges that influence the effectiveness of microbial stewardship. Look, if we can recap the situation, first of all, the one issue is the lack of binding protocols for enforcement mechanism. While national or WHO guidelines exist, they are not always systematically implemented in private clinics. Many prescribers rely on personal habits or empirical choices rather than evidence-based protocols. For example, in 2024, the Health Ministry of Algeria set up a watchdog committee to fight antibiotic resistance, as well as a 5-year plan to reduce microbial resistance in healthcare establishments. But it's only public establishments that are using this plan, not the private facilities. For the second problem, I think there is a limited access to microbiological testing in many private facilities due to cost constraints, time delays, or lack of infrastructure. Many clinicians prescribe antibiotics without waiting for lab confirmation. This results in the overuse of broad-spectrum antibiotics or a known driver of resistance. For the third aspect, I think patient pressure is a major issue. In private care, the doctor-patient relationship is also a customer relationship. Physicians may feel compelled to satisfy patient expectation by prescribing antibiotics, even when not clinically indicated, such as in viral infections. And finally, I think the economic incentive and the absence of institutional stewardship structures in private facilities further awakens IMS efforts. In the absence of national mandates or accreditation requirements, private institutions may not prioritize the fight against antibiotics plan, viewing it as a cost rather than an investment in long-term safety.
Thank you so very much. I think, yes, as you mentioned, some of the issues are common, but then there are also some which are specific. I think next we will hear from Winnie Nambatya. Please tell us some of the issues, few things which are different or which bear repeating. Tell us some of the issues that do not allow private healthcare facilities to actually support the fight, or that things that mitigate against actions in private healthcare facilities.
Thank you very much, Yvonne. Some other issues that we have noted in the private facility are the poor data and surveillance systems. In many of the private health facilities, their data systems are kind of incompatible with the national systems. So that data sharing becomes a bit difficult. Then there is inadequate diagnostic stewardship. So most of the implementing partners, when they go to these facilities, each one of them, the different health workers, they are not done systematically to involve all the health workers at once. So diagnostic stewardship is kind of lacking. The physicians are trained separately, pharmacists are trained separately. So there is no systematic linkage to ensure for the whereby antimicrobial stewardship is time and resource consuming. So many of the private facilities don't really see the need to participate because there is nothing they get in. Okay, there is an advantage that kind of takes time, but most of them are hoping for something to happen there and then immediately. So the incentive to participate is not really there. Then most of the times in my country, private facilities require a memorandum of understanding with the government. So these take a lot of time because they have concern over privacy of their patients. So we don't really have this memorandum of understanding with the private facilities. So those are some of the challenges that I could add to what my colleagues have mentioned. Thank you.
Thank you so much. We'll move to Rebecca Soremekun. Perhaps if you have something new to add, go ahead. But otherwise, if you can just tell us some of the things that you think pharmacists and other healthcare professionals can do specifically. I mean, if there isn't, for instance, a stewardship program already established, what could they do? Or what other activities could they undertake? What other things can they do to ensure that we all together put ourselves into this fight?
Thank you very much, Yvonne. And I want to say that Dr. Dodoo has done a marvelous job presenting the main points. But from the Nigerian perspective, I want to say a major problem is the chaotic drug distribution, which translates into easy access for everyone. Makes access to antibiotics so easy that anyone can just go out there and get it. Of course, the issue of quality is there, but because of affordability, many more people, a good majority, go to private facilities. But when I say private facilities, I'm not talking about hospitals. More of community pharmacies, patent medicine vendors, and even others manned by lower level officers to get their medications. And the community pharmacies are there also to make profit. So many reasons why they dispense. The pharmacists know, and they try to work within a particular framework. But the people coming, they're asking for drugs or medications, and you don't want to disappoint them because of the customer relationship. So they dispense, and so they tend to dispense broad spectrum, just to be on the safe side. Sometimes even community pharmacists ask patients to go and do a lab test and bring the result before they dispense, just to further guide them. But a number of patients, even just walking, demanding specific antibiotics. And the community pharmacists, who at the end of the day also needs to look at bottom line, dispense these things. But what can we do? There are a number of stewardship programs that have been involved with, but they have been mainly in the hospitals, especially in the Southwest, secondary and tertiary. But in the course of one of these programs, we actually brought in community pharmacists for training, because the bulk of this program that was funded by Commonwealth Pharmacists was on education, educating the healthcare workers across, physicians, nurses, pharmacists. In fact, we did a pre and post, and you find that it is very poor knowledge by the time you assess. So we brought in even the community pharmacists to kind of initiate training. And the response was so very good. But thus far, it's been across a region. It's been across a region. So I think what we can do is to create more of these educational interventions. As a matter of fact, a group of us were looking at students, evaluating their knowledge, students in final year who were on the verge of being released into practice. They know nothing, next to nothing, about antimicrobial stewardship. And we saw in the course of research that in South Africa, it is a major component of the curriculum. So we're reviewing, trying to look at the curriculum, hoping to make recommendations to policymakers in our various universities that we need to begin to talk about antimicrobial stewardship from school, from undergraduate level. The study we did is not just pharmacy and medical students, but physiotherapists, nursing, right across. They don't know anything about antimicrobial stewardship. So I think that for me, education, collective education, everybody has to come on board. I stumbled on recently a coaching for physicians on AMS being organized by WHO. So I said, oh, wow, FIP, Commonwealth Pharmacists, we need to begin to coach our pharmacists who are in practice on antimicrobial stewardship. I think I'll stop there for now.
Thank you so much. Yes, you've really added quite a bit to the conversation. And so I'll move to Samuel and ask that anything else. So in addition to education now, we are not just talking about the professionals, we are talking about community members, we are talking about anybody who in any part of their work may have antimicrobials, may use antimicrobials. So what else can we do? And how do you think these measures that have been stated can impact what happens in the community?
Okay, thank you very much, Yvonne. I want to appreciate the organizers for this opportunity. Yeah, I just want to latch on to what the speaker said about education, and that's to say that indeed, yeah, I speak for South Africa at my university. It is well ingrained in the curriculum in terms of training about AMR, and that is very strong antimicrobial stewardship. And I think that is founded on the national strategic framework that has been set by the government to address this particular issue. And I think that is where it starts from. So once we have a national strategic framework, identify various stakeholders within the country and what they are supposed to do to respond to this, I think that's where we start from. And that translates to or being implemented. In terms of the public-private, yes, some studies have found slightly different prescribing adherence to standard treatment guidelines within the public and private. But generally, it has stayed above close to 60% compliance to standard treatment guidelines that have been put there. And so that's another thing. But Winnie mentioned diagnostics, and that's one thing I also want to latch onto. So if we want to avoid empirical response and prescribing, we're thinking about testing this thing before we prescribe. And the quality of the labs is also important, because you can go to any lab and they give you a readout and you base your prescription on that. We're creating another problem. So the National Health Laboratory in South Africa have regular check of microbiological lab, where they send them specimens that they, coded specimens, where they are supposed to test and report back to them. That way, they quality check their processes and their, of evaluating microorganisms. And I think that is quite very important. Now, if you narrow down to pharmacists, I think one thing we must do, recently African CDC, based on what happened with COVID, started genomic surveillance, pathogen genomic surveillance. And I think this is one area that as pharmacists, we can also latch onto. And that speaks to another thing Winnie mentioned in terms of data. If we can drive this and latching onto this, get an understanding of how this genomic surveillance can tell us what new strains are out there. And as we see patients coming in, even in the private sector, you treated someone for a particular disease, infection, 2-3 weeks later, they are back with the same thing. That should raise a red flag to you and say, there is something going on here. And in addition to that, where do you refer them to? So South Africa is also setting up biobanks that allows you to select and collect samples, that you can keep those samples, and you can always, by doing a genomic signature of the samples, know where the source of the infection came from, when did the strain change, and at what point did the strain change. And I think these are some of the things that we need to get involved with in order to respond to this pandemic, as it were. Thank you.
Thank you so much. So we really have quite a bit to do in our as professionals, as healthcare professionals generally, and as pharmacists in particular. There's quite a bit that we can do. I cannot see any questions in the Q&A. If you have any questions, please put them in the Q&A, and then we will read them out. But I see that we have some hands raised, so maybe I will. Yes. Okay, Winnie, your hand is raised. Is that, did you want to say something?
Yes, I just wanted to add onto what Dr. Samuel has mentioned. Some of the work that we can do as pharmacists is place ourselves forward. Most of the times as pharmacists, we kind of don't do what we're supposed to do in terms of appropriate review of our prescriptions to ensure that the antimicrobials are dispensed correctly, the right dose, the right duration, the right frequency. And sometimes when the government or public facilities are encouraging health facilities to conduct audits like antimicrobial use and consumption, we usually don't engage. And this is some of the work we can do, conduct regular audits, both consumption and use, and patient education. Every time you dispense an antibiotic, ensure to educate the patient because they are key stakeholders. We need to also participate in formulation of institutional medicine lists and formularies. So as pharmacists, I feel that's where we can make some change with regards to antimicrobial resistance and stewardship. Thank you.
Thank you so much. Cornelius, you wanted to add something?
Yes, please. I totally agree with Winnie, the point she made on, keeping track of antimicrobial use and antimicrobial consumption. This is something that's, in a number of facilities, you have electronic health records, and this is something you can easily tease out from your system to help you know what as an institution you are using. And this can go a long way to promote your stewardship activities. And to add to it, in instances where you're even having challenges, I think showing some evidence can help you to win some favor before your hospital management. Provide evidence of data on antimicrobial use, antimicrobial consumption. Our colleagues in the lab can provide data on antimicrobial resistance patterns. And I believe any facility that is looking to be up there, based on the findings, would want to find ways to improve upon these, and this in effect to reduce, antimicrobial resistance. There's also another point I want to make. We often talk about substandard and falsified medicines. You can actually have a very standard medicine, but how you take care of that medicine can lead to that medicine being substandard. Let's look at the storage of antimicrobials. You can buy a quality product, but if the product is to be kept at 2 to 8 degrees Celsius and you keep it in the open, obviously you are making that product liable to degradation. That will in effect make that product substandard. If it's to be kept away from sunlight, there is a reason for that. All right. So let's look at how we store our medicines to prevent them from becoming substandard. And this can also be, translated into the discs that are used in the lab for testing. I mean, you get it fundamentally wrong when your disc you are going to use for testing has also lost some amount of drag in there. Because even though you are testing, whatever you are using to test, on which you are going to make informed decisions, it's already flawed. So let's look at how we are storing our drugs. Let's look at how we are storing our testing disk. And I believe that will go a long way to help in this fight. Thank you.
Thank you so much. So I hear that in addition to our general practice as pharmacists, whether in the public sector or in the community or in private, we have to, there are other things that we may not be part of what we were trained to do right from the word go, but which we still maybe need to take a look at. And I think that is why, Dr. Dodoo, you mentioned some of the resources that are available to us as pharmacists, various places that we can have access to these resources. And I think two things that have really come out is how we use, analyze, and understand the data that is available. Indeed, how we even capture the data, and also the supply chain, managing the supply chain so that by the time the medicine moves from the production to the consumer, as pharmacists who understand the ways in which the medicines must be stored, by the time it gets there, it is still efficacious. And we don't start off having a product that is of good quality and then it becomes substandard by the time it gets to the consumer. But so thank you very much for all of these. And I'll ask once again, perhaps maybe you can raise your hand if you, as panelists, if you have some questions. I see some questions and answers popping up and they are being answered by the panelists. And so once they are being answered, we are not going to read them out. We will ask that maybe if you have something, if you want to know what they are and the answers, please just go into the Q&A box. You'll see the questions and the answers that have been given. If no answer is given, we'll read it out and ask our panelists is how do you see the involvement of community members when we are looking at private facilities? How can we link up community members to ensure? I believe that in the presentation, Dr. Dodoo, one of the things you talked about was that consumers should not be demanding certain antibiotics. But how do we get consumers, how do we get to that behavioral change point, both from consumers and from healthcare professionals? Anybody who wants to, any of our panelists, you can raise your hand so that I call you to address that for us. Right, Winnie, please go ahead.
Thank you very much, Yvonne. So under the Commonwealth Partnerships for Antimicrobial Stewardship, we have tested the hub and spoke model, whereby the health workers or the health facilities that are empowered at the hubs, and then the lower health facilities and community members are the spokes. So what has worked best with us is that during the training on AMR and antimicrobial stewardship, the village health teams are empowered, because most of the times community members feel not empowered to speak up. But when you use the same people within their localities, like village health teams, or some countries refer to them as community health workers, they are able to learn from them and mimic what they are taught and spread this information to the other community members. So it is basically designing empowerment messages. You can use local community radios, involve the local leaders, traditional leaders. For example, clan leaders also are helped to disregard particular beliefs that are not related, could escalate antimicrobial resistance. Thank you.
Thank you so much. And so I'll, Rebecca, you also have something to say. Please go ahead.
Thank you, Yvonne. I actually had my hands up for a while, but I will speak to...
My apologies, my apologies.
I'll speak to the point that is currently on the table in terms of getting across to the people. In Nigeria, we also, especially, yes, across the country, we also do this through the motor park, the unions, transporters, because even antibiotics are sold in the vehicles. So the regulatory authorities, also with the government, they educate transporters. And as a matter of fact, sanctions are imposed that if antibiotics are being found to being sold in your vehicle, you are going to pay this and this, or your vehicle will be seized. And so they become the voice of the government, just to say that no drugs are to be sold in traffic. And this is also helping. The point I was going to make earlier, I think it was Samuel that talked about the quality of laboratories. Yes, sentinel laboratories are being set up in Nigeria through international support, that laboratories are being evaluated and certified. Even though, yes, we have so many labs dotting the whole place, but not every lab can bring out results that are truly dependable. I just wanted to make that point. Then on the issue of data, recently the government of Nigeria set up an antimicrobial stewardship task force, which, yes, is still under the Center for Disease Control, but the focus of this task force is about data gathering, mapping antimicrobial resistance in the country, across the country, which antibiotics have failed where. And so we have a map. So we know which areas to now look at, and also to do, collate researches that have been done. So we have the data concerning antimicrobial stewardship, researches that have been done across the country, as well as was the third one. I think I'll maybe drop it for now. I'll drop it later.
Thank you so much. Arinola, your hand was initially up. Do you want to speak?
Yes, I just wanted to draw attention to the questions in the chat box. Some of them, as you mentioned, have been answered, but we have a few that I think we should discuss live. So Christina, okay, Winnie has started answering that.
Please go ahead and read them for us, and let's.
Okay, so Christina says that, what have you found to be most helpful strategies in educating the public on the AMR threats and appropriate antibiotic use? What verbiage resonates best with the public? What platforms or tools do you use for public outreach? And what are some of these success stories? Winnie, I think you can just take that since you're answering on the platform.
Thank you very much. So one of the strategies we used in Uganda are the patient stories. We got some particular patients that had been affected by antimicrobial resistance. And actually, when our members of parliament heard these stories, they knew that the community and the population is affected hugely. And we actually formed a parliamentary forum on AMR. So engaging the actual patients that have suffered from antimicrobial resistance is very good. So that's what I wanted to mention. Thank you.
Okay. Are there any other additional comments to that on what platforms in reaching the community? Because we know that a lot of the times the pressure from the public from the patients, even in the hospitals, to dispense an antibiotic or to prescribe an antibiotic is huge. And especially we're talking about private health facilities, community pharmacies, clinics, private hospitals. They are there first as a healthcare service, but they're also there as a business. And so they need to also balance out that aspect of their livelihood. So what are some of those strategies that were found to be useful in getting patients to agree that, oh, you don't need an antibiotic for this condition, even though you have asked for it, and this is something that you need better? Any other takers for that question?
Right. So
Cornelius, you want to help us? Okay.
Yeah, so I think it's education and letting the members of the public know the effects of AMR. I think whenever the opportunity presents itself, we need to take it to educate, because I think once the public understand the impact or effect of antimicrobial resistance, I think it would make some progress with behavior change. We can always link it to COVID. COVID was quite short term, but antimicrobial resistance has been around for a long time, and its effects are way more than COVID. So I think we just need to educate them. And for us, aside going onto the radio stations to reach out to the masses, another thing we do, which may be a bit unconventional, is we have a number of T-shirts that we usually print messages on, and we give to our members in the hospitals and other colleagues we work with. And you don't wear a T-shirt once, you wear it over and over again. And whenever you wear it and someone sees the message, they read it, they may ask you a few questions, and it presents an opportunity to educate. And some of these messages are quite simple and straightforward, like, wash your hands regularly. And I mean, subconsciously, you are sending a message across without literally opening your mouth. And then, I mean, we live in a digital world now, so we also do a lot of digital assets. So we have a number of flyers we design ourselves, and we flag on our social media statuses and other platforms and reach out to different audience as well. Thank you.
Excellent. Thank you very much.
Thank you. Arinola, is there another one? Okay. So I was asking if there is something else we may have missed, if maybe you've identified another, or if that's it, Then Winnie,
yes,
your hand is up.
there's
Yeah.
another question on, can you elaborate? Somebody had asked, sorry, Winnie, somebody had asked a question on, Cornelius talked about antimicrobial return, the take back program for antimicrobials in Ghana. You know, so somebody is asking to elaborate on that. Is it just for private facilities? Is it for hospitalized patients as well? And then just to add this question to that, I believe the patent medicine vendors are the major enablers of antibiotics use. This is for Nigeria, as well as the open drug markets. And I think there are open drug markets actually in most of our countries across the continent. You know, so Cornelius, from you, the Take Back program, and I don't know if there are Take Back programs in any other country represented here, so you can also share. Thank you.
All right, thank you very much. So the Take Back program is actually an initiative that was started by the Food and Drugs Authority. It was being piloted in certain parts of the country, but in our region, this wasn't there. So we collaborated with the Food and Drugs Authority to bring it into our side of town. And we basically, it's mainly for the general public to return any leftover or expired antimicrobials. We pretty much opened it for all medicines, to be honest. We intend, stratify these into the various classes to return any leftover or expired medicines they have in their homes. We educate, we go onto the radio stations periodically to educate the general public on this. We use other fora as well. We go to the markets, we go to churches, and we go to schools, basically to talk about this and let them know the effect of having these expired medicines at. So we don't want these to be flushed down the toilets. We don't want these to be mixed with regular waste to end up at dump sites. So it's basically an initiative to reduce antibiotics and other antimicrobials that end up in the environment because of the effects it has effectively eventually on antimicrobial resistance. So yes, we mainly educate, and we have this in community pharmacies. We have take back bins in community pharmacies because of easy accessibility. We also have these bins in hospitals across the region as well. We just try to have as many take back points, not to inconvenience the consumer or the member of the public who wants to return his or her medicines. Thank you.
Can I just ask for a follow-up question? When you collect these drugs, what do you then do with them, and at whose cost?
Yeah. So that's for the public. It's a collaboration we have with the Food and Drugs Authority. So the Food and Drugs Authority, that is the authority or agency that is mandated with the proper disposal of these, then picks these up, and then, they properly dispose these of, we have a site, and then, the proper mechanisms are done to ensure these don't end up in the environment. So it's a collaboration with the Food and Drugs Authority. The member of the public returning this doesn't pay anything. And yes, it is different from institutions that have expired medicines and they want to dispose these of. There is a laid down procedure that you contact the Food and Drugs Authority for. But this take back program is solely for members of the public to return any expired or leftover medicines they have at home.
And the mechanism of the Food and Drugs Authority picks it up from the pharmacies or the hospitals where these bins are and disposes and starts the disposal process themselves. All right, thank you very much. Any additions to that from anyone?
Yes, at the moment,
yes. Okay.
They have a schedule of, I think every 2 weeks, they go around the region to pick these up. So yes, it's very routine.
That's great.
Yeah, thank you.
Okay, just to
Samuel's hand is up.
my hand is up. Sure, I'm
Please,
not.
let Rebecca
Okay.
finish, then Samuel.
Yes, Rebecca,
Yes,
please.
just to add to the Take Back program, I know that in a few hospitals, these have been put in place so that when a patient's prescriptions have been reviewed by the physician and maybe medications are changed, the pharmacy encourages them to return the other drugs. Because typically the practice is to take those drugs back home and give to anyone that may develop a similar ailment. But the pharmacy of the tertiary hospitals, 1 or 2 particularly, I encourage patients and they go around, the wards and take back these medications and add to the credit of the patient, so the patient can use it to collect other medications. That is ongoing.
Thank you. Samuel.
Yeah, thank you. A couple of things I just want to respond to in terms of engaging the communities in this fight. I think one of the approaches is to engage them as part of our research. We don't usually involve the community in our research. And I think once we start getting them and letting them lead the research, and they are communicated the impact of the outcome of that research, we get more involvement, more participation, and they are able to also, appreciate, and you have greater change in depth of behavior. That's one thing. And also speaking to the last in terms of disposal of antibiotics, there's been a research by a group here that looks at the marine organisms and the water bodies and found, significant amount of antibiotics in those water bodies. And what I like about what they did, they had a forum where this was communicated to the general public. And I think this is one way for the public to see the extent of the problem. And if they see the extent of the problem, it's raised that red flag, and these strategies that Dodoo just outlined can now be adhered to in terms of disposal. But we need to get this information to them and have that platform to communicate our research as well to them. Thank you.
Mohammed, do you have anything to add on the disposal of medicines in Algeria? Is there any such program? Mohammed, can you hear me?
Yeah, I can hear you. We have, as I said, we have already a plan who was put in motion by the ministry, the health ministry of Algeria. So it's a plan who was put in 2024. It's there is a watchdog community to come to fight antibiotic resistance, and this plan is extended on 5 years. So it's tend to reduce microbial resistance in healthcare establishments, and actually we tend to find how to link private communities with private communities with public communities. It's a very difficult point. Some action has been made. First of all, we use simple culturally appropriate messages through media, schools, and social platforms. We also train community health workers and pharmacists to communicate responsible antibiotic use. We also collaborate with local leaders, religious figures, and educators to reinforce the message and promote behavior change by addressing misconceptions like antibiotics cure all infections. We tend to encourage the public to avoid self-medication and to complete prescribed treatments, set up feedback systems so communities feel involved and heard, and provide access to reliable and affordable healthcare, reducing pressures to seek antibiotics unnecessarily.
Thank you very much. Thanks a lot. Yvonne, over to you. Thank you.
Thank you. So I think that we have responded to all the questions that have come in. And so we are still around for the next few minutes, but I will now resume sharing.
Sorry, Yvonne, there are 2 more questions that have entered the Q&A.
Okay.
Let me quickly read them. So this one says, do you think pharmacists serving as supplementary prescribers as in the UK can help? And then another question is that, what if we develop a proposal and want to do antibiotic stewardship program? If any international organization will fund it, in this case for private hospital management, in this case, private hospital management they agree to do the project. During the project, the investigator can share his views or intervene as needed. And this is much needed, So I think this question is about looking for collaboration around doing a study in private hospitals, just as Sam mentioned, that involving in research. And then one other question I would like all of us to answer is, if we have the same problem in Nigeria, I don't know if they're the same problem in Nigeria where everybody has access to everything. I don't know if that's the same in your country. I would just like to know whether that's the same in all the countries represented by the panelists, that patients have access to everything, antibiotics, drugs for chronic conditions, prescription drugs, even controlled drugs, so, and if this is a challenge and how you are going about it in your country. I'll start with Samuel.
Yeah, thank you so much. So I don't think that is the case. There's a very good control here in South Africa. But having said that, I have a student that's looking at some illegal platforms, particularly social media platforms, through which some of this has been distributed. So those are the holes that we currently have.
All right. Mohammed, in Algeria?
Yeah, I think it's a great and important questions. So in Algeria, there are national regulations that classify antibiotics as prescription-only medication. However, the enforcement of this regulation is not always consistent, especially in community settings. In many areas, antibiotics can still be obtained without a valid prescription, contributing to misuse and resistance. And just to know that antibiotics in Algeria are only sold in pharmacists. We can't find any antibiotics in other locals. In recent years, there have been efforts to self-control, including awareness campaigns and pharmacists' responsibilities and stricter monitoring, but challenges remain. It's very difficult, particularly due to high patients' demand and limited oversight in some private pharmacies.
Thank you. Cornelius, you want to answer for Ghana?
Yes, please. Yes, we have an issue with access, and I think it is important that we treat these as prescription-only medicines and only give them out when there's a prescription accompanying these. There is the issue of the borders as well. I mean, with proper border control, we'll be able to control or check how some of these products get into the country. Thank you.
All right, thank you. Winnie, for Uganda.
For Uganda, it's a similar challenge. Despite the regulations, people have access to all levels of antibiotics up to the reserve ones, plus the porous borders.
All right, thank you very much. So it's a common enough problem, let me put it that way, across the continent. So we really need to be finding homegrown solutions to these problems, because sometimes when we listen to some of the presentations coming from the global north now, some of the solutions, we may not be able to apply them wholesale because our starting level is completely different from what we're talking about, So having this discussion, and somebody put on the question earlier about if there are any collaborations in universities on antimicrobial stewardship. And I think Mohammed answered and said that there are collaborations starting, but if you are interested in starting any, you can link us through the African Pharmaceutical Forum, and then we can try to see how we can link interested researchers and interested sites, interested schools together. Also, the question about supplementary prescribers, again, that's something that we are a bit of a way from getting to, because we have not yet even I don't know about other countries, but in Nigeria, we also have the issue of it used to be a Cold War, but it's now getting to be a more violent and verbal war between pharmacists and health practitioners and medical practitioners, physicians, where the current battle we're having now is the battle against consultancy cadre and doctor of pharmacy for pharmacists, you know. So we're not yet even seeing ourselves as a team before we'll be talking about supplementary prescribing rules for pharmacists, you know. So it's still a ways off. We'll need to sort out the salient issues first to be able to work together as a team before we can then be evolving some of those other additional responsibilities. So, and then on the issue of the proposal, as I said, let's hear you on APF. I'll put the APF website on the platform, and we can begin to do some collaborations. Right now, the African Pharmaceutical Forum is trying to midwife. We've been trying to do this midwifing for a while, an association of schools of pharmacy across Africa, where we'll have a common front to unite, to network, to collaborate, to share expertise across the region so that we can grow our pharmaceutical industry uniformly and together. There are some countries that don't have a school of pharmacy at all. There are some countries that the schools of pharmacy are still completely subsumed as a department in the College of Medicine or in the School of Health Sciences. And then, of course, there are those of us that we have independent faculties of pharmacy. But if we can find a way to bring all of us together, and this association is a direct deliverable of the FIP Unitary Program of FIP with UNESCO, where it was adjudged that if the universities, if we can all come together, we'll be able to help ourselves better as a continent, seeing the same things and growing in the same way. And then we'll be able to take on some of these things together. So I'll put the APF website on the platform, and then we can have further discussions outside of that. Over to you, Yvonne.
Thank you so much. And when you were talking about the schools of pharmacy collaborating, there were lots of emojis showing that it's something that people really think will help us as a continent. So APF will be depending on you and also waiting to hear from you on what the next steps are in that regard. So I believe we have finished with all our questions that have come in so far. We set out with some objectives. We wanted to look at healthcare, private healthcare facilities, and how we could engage them as pharmacists and other healthcare professionals to to play an active part in the fight against antimicrobial resistance. And I believe that everybody who has participated will agree that we have met our objectives. We have discussed what pharmacists can do. We have discussed ways of establishing antimicrobial stewardship programs. We have even looked at how and why we should use data. We've looked at other things that pharmacists can do even in the public sector as well as in the private sector. So I think that we have met our objectives. And I believe I stand with APF when I say that there are other webinars which are being planned for the rest of the year. And so once you hear that there is something else coming up, please join us and let us learn. Also, with the AMR Commission, there are other webinars. I think about 3 weeks ago, we had something on malaria. There are other webinars that we will be collaborating with other agencies of the FIP to bring to you. So please be on the lookout and join us. So you can also look at our events .fip.org, and you will see all the other digital events that are coming up. Please be going there frequently so that when new events are introduced, you will become aware of it, because once they are organized and they are finalized, they will be put on this page. So visit events.fip.org, and that will keep you updated on what is happening in FIP. Do not forget that we are the 83rd FIP World Congress of Pharmacy and Pharmaceutical Sciences is taking place in Copenhagen, Denmark from the 31st August to the 3rd of September. And the theme is Pharmacy Forward: Performance, Collaboration, and Health Transformation. I believe that right now, all of us who submitted our abstracts, we've received feedback. And from the reports that came, there was a phenomenal number of abstracts that were submitted this year. And so we should be expecting to have a very, very educative time with respect to the posters and the oral presentations that we will be seeing at FIP. So start preparing, and see you in Copenhagen. Yeah, so thank you so much for attending. Thank you for participating, and thank you for keeping. I mean, we were looking at maybe about 150 people participating. At some point in time, we were 203, which is great. And so we are very happy that you have been able to join us. And as you have seen from the chat box, whatever information you need from the FIP, just go click on it, and you have that information which has been given. We know APF is also communicating with us. Please be active also in the African Pharmaceutical Forum, because that is the body for pharmacists in Africa represented in FIP. And so, having said all of that, I will also say a very big thank you to our panelists. You have made this great. You have responded the questions that came. You have answered them. You have fielded them, and we've seen the expertise that we have, but we've also seen the opportunities that are available for us as pharmacists on the continent to build our capacity and also to impact this fight against AMR or across the continent and across the globe, because AMR does not know borders. So thank you so much for coming. And thank you, Professor Arinola, representing APF. You have done a fantastic job with this webinar. Thank you so much. There are also people behind the scenes. Albina, you are behind the scenes. You are there. Thank you so much for all that you have done to make this a successful meeting. And with that, I'll say, may God bless us all, and see you again when we have our next webinar, or at least see you in Copenhagen. Thank you. Bye-bye.
Before you log us off, Albina, I would just like for people to take the next 1 or 2 minutes, if they have not checked the Q&A box, for some of the questions that were not answered live, so that they could take the learning from there, because there are many questions that were answered directly on the platform. So in case you did not check, we have like 2 minutes before we'll be logged off, so that you can please go and check the Q&A box for those questions and those answers, so that you can be updated on the information that is shared. Thank you very much for joining us, and we look forward to seeing you in the next APF webinar, which will be discussing sports pharmacy across the continent, pharmacists in sports, and the issues around that. That will be coming up sometime in June. We look forward to having you all. And so I'm just drawing down the time so that people have a few minutes to look at the question and answer box. Thank you to all our panelists, and those that allowed me to drag them by force, those that came willingly. Thank you very, very much for being here, and for blessing us with your expertise. Thank you very much, and bye-bye, everybody.